Okay, could I ask people to take their seats? Could I ask people to take their seats? So we're going to start soon. We're going to start in a minute. Okay, good afternoon, everybody. My name is Ludwig Zrinzo from London, and I'm here on behalf of Boston Scientific at the moment to present the lunchtime lecture. I'll be joined by Professor Chabardes later as co-chair, and we're very, very honored to have the Würzburg team today to talk to us about their experience of using the directional lead. I think I'm right to say that they are the center with the most experience in directional deep brain stimulation. And I think we'll kick off the proceedings with Dr. Cordula Mathis, who's going to talk to us about her experience with directional leads. Thank you.
Thank you very much, Ludwig, for the introduction. And thank you to the organizers for this very special Congress. I really like to be here, not only because it's the first live event, but really because of so many excellent presentations. I would like to speak on directional leads, an experience of the last 6 years at our center, and I will go with you through the background, the conceptual ideas, our application and experiences and future ideas. And the idea of directional leads came upon mainly based on anatomical, physical, and bioengineering ideas that when we deliver electric field around the electrode, around the SDN, that the tissue there is rather inhomogeneous and anisotropic, and so the field might be distorted by the neurons or the axons, and we really don't know which of those we are activating. And everybody of us wished to have a more individual adaptation of the stimulation volume and direction. And the major work in this field has been done by the group around Batson and McIntyre. And over 10 years, there had been several ideas. The mouse does not work. Sorry. There have been. Do I have a pointer? No. Okay. There have been several ideas, mathematical ideas. The Sierpinski model, for instance, that aims for a more precise, but also activation of more neurons. And then there were models with up to 32 electrodes, sensing and stimulation. And it could be shown by these groups that this was feasible. Until then, finally, it came into clinical practice. In 2015, they were introduced into the clinic by Abbott and by Boston Scientific, and our major experience is with the Cartesia device. And as you see here, meanwhile, we have implanted over 200 patients with directional leads, and recently we also got some experience with the SenSide directional leads. The major indication in our hands is for Parkinson's disease and also tremor. And the strategy of insertion with this device can be either in AP orientation or mediolateral orientation. We favor the anteroposterior orientation in order to shape the field in an anterior or rather oblique direction. And we took in the beginning rather a lot of energy and time in really positioning and rotating the lead in an AP version. And you see this quite nicely. The sharper you see the lateral, in the lateral view, the marker, you are sure that you have well placed the electrode. And we're usually planning the lead implantation 3 millimeters below ACPC. At surgery, very often we identify 4.3 millimeters below ACP as the best test level. And in order to position the directional leads at this level, we, in the beginning, took the habit to implant one level lower, 5.7 millimeters on average. And then we had to find out that later on, our active level in the first weeks and still after half a year was even 2 levels higher. But usually we were still able, in the most effective area, to position the directional leads. We have realized that compared to ring leads, we have changed the selection of additional trajectories. In our ring lead session, we used about 3 to 4 microelectrodes, and very often we use a 45-degree turn, whereas with the directional leads, we tend to use less microelectrodes, on average 2 and sometimes 3. We chose the central trajectory more often, in 60%. And this is major due to the fact that we accept a smaller therapeutic window with directional leads. So when we see clinically at testing that the sweet spot is really at the central trajectory, but the window is rather small, nonetheless, in most cases, we will accept this trajectory because we know we can compensate with regard to side effects by the directionality. And at surgery, the best surgical effect is usually achieved by 1.5, 9.7 milliamps. The surgical therapeutic window is fine by 3 milliamps, but you also see, when we take into account the standard deviation, that we accept therapeutic windows of 2 to 1.5 milliamps, which is much less than before, and this is also due to the fact that we know that we can compensate with the directionality. After surgery, the amplitude goes a little bit up, but it stays rather stable for a long time. Does surgery take longer? Yes, it takes a little bit longer with directional leads. This is really the whole procedure, starting with the stereotactic frame, doing the computer tomography. So it's only a few minutes later. What becomes longer is about half a minute of fluoroscopy, and also the dose of fluoroscopy goes up. This is not statistically relevant, but it has to be considered. And this was mainly due to our eagerness to really position the electrodes in the AP view. Is this really necessary? As I mentioned, we try this, but we see during surgery, within an hour, during doing the second side, we see some slight rotation of the marker, which means by rotational power, torque occurs, and so this, this position changes, and we have to control the final position of the leads after surgery. And my colleagues from urology, Dr. Lange and Dr. Kapesian, have undertaken this analysis, and they applied the methods that were developed in Freiburg and in Cologne, the diode mode and the rotational angiography mode, and we identified that both modes work well, and are really corresponding very well with each other. And in the majority of patients, we find a deviation at day 1 after surgery, at the first CT control. But thereafter, at our 3 months or 1 year control, we did not observe any further rotation. So there was no additional torque after day 1 in our patients. So we can confidently perform the programming then. Programming will be the topic of the next talk, so I only mention that now the radiological identification of the marker and of the rotation and the position of the directional leads in the SDN area is essential, and this is the basis for the early programming. And the monopolar review, which was the gold standard for long, now is performed only after 3 months in our team. What kind of VTAs are we shaping? We do not know. Nobody knows. It's just a modeling. But we can tell that from the combination of electrode contacts that we use, only 45% of patients receive a symmetric VTA by our programming, so a pearl or a pearl chain. But over half of the patients, they are treated with asymmetric VTA programming, pearls or these Pisa mushrooms, where we combine a cylindric stimulation with an asymmetric round stimulation. And steering in our hands, in the majority of cases, is medial. Why is this? Because we usually go for the very posterolateral position of the SDN. Coming to surgical sequels that might be specific to directional leads. We, in the whole series, not only directional leads, we did revisions. We offered revisions to 12 patients. And in 3 of these patients, we just exchanged the leads by a directional one. And in 4 patients, we performed a lead lifting in order to position the directional contacts in the more favorable functional area. And coming to allergic edema, we experienced this in 16 leads in 11 patients. It seems that allergic edema might appear a little bit more often in directional leads than in ring leads. But I think it's too early to tell, but we even experienced it in our young series with Sensite directional leads bilaterally in 1 patient. And all patients recovered, some within a few days. Maximum period was 3 weeks, though. My colleagues from neurosurgery, Dr. Nickel and Dr. Fricke and Sylvie Mais, they performed an analysis, retrospective analysis, but based on very standardized, prospectively collected data, and compared ring versus D-lead implantations by UPDRS-3 in off and on modes, and they compared the programming parameters, the lead positions, and so on, after 1 year of surgery. This is a small series, but very precisely performed. You see that the groups by age, by male and female gender, by duration of the disease are very similar. And the majority of directional patients were also stimulated in directional mode. We set the level for a responder quite high. That means 75% response rate as least. That were these patients that we identified as responder. As intermediate responder, those who have an improvement in the stimulation versus medication response by 25 to 75%, and non-responder. We see the data are quite similar in both groups, slightly better in the directional cohort. And this is visible also here. The responder and also intermediate are slightly more in the directional group. But statistically, this is not different. And also, all the specific data are not statistically different, at first sight at least. So the Höhn and Jahr classification is similar, the medication off and medication on before surgery, and the levodopa challenge effects and the stimulation effects are similar in both groups, as are the response ratios. So why do we still stick to directional leads? Here we see the clinical outcome in the ring mode versus directional mode. First, the medication off situation, severity of disease, even a little bit more severe in the directional mode. We see here by standard deviation. And then in medication on and stimulation on modes after surgery, very similar improvements. So we tried to identify what could be the reasons that all the data seem so similar, and we looked in detail into the lead position, the distance relative to planning, and compared it. To put it brief, there was nothing statistically really evident, and also correlating the distance relative to planning, correlating it with UPDRS also did not bring us really further. Then we looked in the stimulation parameters further, and there we see that the amplitudes in the directional leads are significantly smaller for the right and the left side. And the pulse width is similar, so we did not try to compensate side effects, for instance, by smaller pulse width. And the frequency is lower as well. So even if we consider that impedances are somewhat higher, I believe that obviously the delivered electric field is smaller and more precise. And especially we see this with the frequency difference as well. Another reason why we surgeons are especially pleased to have directional leads is with regard to safety. We cannot always implant the leads the way we would like to. And that is especially the angle by which we enter the subthalamic nucleus, and specifically its posterior part, posterior to medial part. If we want to avoid the sulci, if we want to avoid all the vessels, then we need to adapt the angle of entrance. And this also is quite important for the electric field that needs to be shaped thereafter. And therefore it is so important to have this opportunity of directionality. To give an intermediate summary, directional leads are straightforward to implant in our hands. They widen the opportunities for small as asymmetric VTA. In about 55% of our patients, we use asymmetric VTA. The response ratio overall is similar, but at lower amplitudes and frequencies. So we may ask, is this more efficient, more specific by directional stimulation? And do we, by this, obtain a better network retuning? So this is more questions than answers. And briefly, I would like to finish going to the new leads that are in study now. And we have been using, excuse me, in 6 patients, the Cartesia X, which has 5 levels of directionality. This implantation procedure overall is very similar. We are now taking more care in order really to fix the height of the electrode, to have the real vertical control. And here we see the first implantation with the team at the day of surgery. And the idea behind this is the multifocal targeting of the substantia nigra, of the nucleus, and of the sonar inserter. And this is very easy to be explained to all the patients. And this is one case of a patient in whom we performed a lifting of the normal Cartesia lead, which would not have been necessary if we have had extent at that period. And we are aware also that focused ultrasound indications are changing and are being widened. And also there comes up the idea to treat Parkinson and to tackle the different issues of the disease by applying lesions to sonar inserter to the medial part of the SDN in tremor or the more postural part for rigidity. So these are the aspects that could be important with new and longer directional leads. Going back to the beginning, do we wish electrodes to increase the number of activated electrodes and neurons? I do think no, rather not. I think smaller stimulation amplitude, a smaller, more specific electric field, a lower electric density is probably important in order to remodel the network, the motor network. And at this point, I would like to stop and thank our interdisciplinary team and you for your patience. Thank you.
Professor Mathis, can we ask a few questions before you leave the podium? Sorry. Are there any questions for Professor Mathis before we let you down? Then we can have a more comprehensive discussion after Jens gives his talk. Please.
Thank you for your elegant presentation. I'm interested in this concept that the electrode turns in the first 3 months, I think you were saying. And after 3 months, the chance of the electrode actually turning is reduced, if I understood you correctly. So what is it that you account for this rotation of the electrode that can confound the placement? Is it the fixing of the electrode? Is it somehow the tissues change? Give us your thoughts, if you would.
Yeah, thank you for the question. I think it is a discussion and it's ideas and hypotheses. We have to understand how the leads are constructed. They are constructed with wires along spirals. And so by bending the electrodes at the skull, which we need to do, whatever type of fixation we use, we transfer a certain energy onto these spirals. And the tension which is in the part within the brain might change. So this is most likely responsible for the very early rotation or torque that occurs. Another aspect which has not been taken into consideration in this first analysis is that the stereotactic frame is never, ever completely AP, completely parallel to the ACPC. So therefore, this is something which we need to calculate as well. But according to our experience, if there is nothing like loosening at the fixation or so, which has not occurred, after the first day in our hands, there is no further rotation. Okay?
Do we have any other questions from the floor? I actually have a few questions myself, but I'll leave most of them for after Jens' talk because he might cover them. But from the surgical point of view, I'm quite interested in the edema that you saw around some of the leads. And I have a few questions about that. And first of all, how did it present? How did you find it out? What did it look like on the imaging? How did you manage it? How long did it take to settle? And why is this allergic edema and not edema due to several tracks, due to microelectrode recording, for example?
Oh yes, that's an idea. But it was not associated with patients. I would look into it in detail, coming back to your last point, but it was not in patients with many microelectrodes or so. No.
But did it settle on its own?
Pardon?
Did it settle on its own? Did it just take time and go away, or did you have to explant or things like
First of all, what you asked first, I think is very important, because we could suspect that there is more edema occurring which we do not notice, which we do not diagnose. Those patients in whom it became evident, they presented with a kind of more apathy after 5, 7, 10 days. They were less energetic, although they had been very, very positive, like with a stun effect in the first days, and this seemed to subside rather suddenly. And some patients, 2 patients, it even went mute. They would hardly talk. If you asked them, they said everything okay, but they really became rather mute. So it was frontal symptoms, and that was the reason why we did CT. But some patients might be already at home when they develop this. So these 12 patients are those 11 patients in whom we detected it. And we followed them until we could see that in the CT it subsided, which in one case took 3 weeks. And I think in 2 or 3 patients we used dexamethasone.
Thank you.
I don't know what do you use?
We have also seen this in a few patients. Not in as many. I think I can recall 5 or 6 patients from over 1,000. But we have very similar presentations with as you say, some cognitive blunting and apathy. And then we see some edema on the post-op scan. I think one patient actually took 3 months to go away completely, but it did subside. We were worried in that patient whether it was an infection. It was just that the timing of the edema was, you don't get an infection 2 or 3 days after the operation causing them. And we didn't treat with antibiotics and it resolved. But it's an interesting concept, and I don't think that we've experienced a difference between the quadrupolar leads and the directional leads.
Yeah, I'm not sure about this either. I suspect rather it is an hypersensitivity due to the softness in the silicone.
Maybe.
And the concentration is so low that this goes away with the CSF. That is the concept of people who are in this field of allergies. Yeah.
Thank you very much for an
Thank
excellent
you.
talk.
Thank you.
So it's down to me to introduce Jens Wolkman, who's going to give us the neurologist's perspective of dealing with directional leads after the last 6 years. Jens, thank you very much for coming.
Thank you, Ludwig. Hello, everyone. It's so nice to see so many familiar faces after such a long period of time. So my role here is to talk about the increased complexity that we are facing with directional leads in programming and postoperative management of patients with DBS. And we had to deal with this increasing complexity and find our own workflow in Würzburg, which was strongly relying on imaging and image-based programming methods. And this went very nicely along with the development of tools that are now commercially available by Boston Scientific. So the traditional and classical way that we are using in neurology for DBS programming is a purely clinically oriented way of deciding which of the contacts of an electrode are preferential in terms of clinical outcome, benefit, and also safety by acute stimulation response testing. And this is known as the so-called monopolar review. We keep basically all the settings constant, use 60 microseconds, 130 hertz, increasing amplitudes, and then we test in a monopolar mode each contact clinically and determine a threshold for clinical response. And then for the safety margin, which means the threshold, the amplitude threshold at which adverse effects occur. And this allows us to create a kind of a patient and electrode-centered stimulation response map. And this is an iterative approach where we have to do and repeat the clinical evaluation and observe the patient. Of course, it's tiring, it's time-consuming, and there are a number of clinical issues also with this type of programming that has been used for the last 25 years. So one of the main problems is that we know today that the stimulation responses that we are observing are not all immediately established with deep brain stimulation. There are some responses that we can observe within seconds, and there are some indications where you can really titrate the stimulation amplitude according to clinical response observation. This is, for example, the case in Parkinsonian tremor or in essential tremor, where you have an almost instant response of the symptom. We can also, in Parkinson's disease, easily monitor rigidity, which is quite responsive to stimulation, quite immediate. But there's very poor titration for dystonic symptoms, for gait disorders, definitely very poor response for psychiatric symptoms such as depression, for example, where you're not expecting an immediate but rather a delayed neuroplastic response to neurostimulation. The classical monopolar review does not reflect also some more advanced programming options of novel DBS devices such as anodic or multiple programs, etc. So it's just a fraction of the options that we have, which basically is used as a model to create the stimulation response map around the electrode. And above all, it's very, very time consuming. And then there is increasing evidence that we are underestimating with that kind of clinical approach long-term adverse effects by just evaluating short-term adverse effects. And this is just an example of the increasing number of long-term stimulation adverse effects that we are observing. This is a patient with cervical dystonia whom we operated in the internal pallidum, and 6 months after surgery his cervical dystonia was almost completely abolished, but he developed a Parkinsonian syndrome, including a resting tremor, gait disorder, bradykinesia, and we were wondering whether he had Parkinson's disease. Did a DUT scan? The DUT scan was completely normal. And then we switched off his stimulation for 24 hours. There was no immediate response. His cervical dystonia came back after approximately 1 to 2 hours. And his Parkinsonism completely went away after 24 hours of stimulation washout. So there are these kind of long-term neuroplastic network changes that may give rise to adverse effects that we are underestimating. This has been described for gait ataxia, dysarthria, gait freezing, and other phenomena in various indications in cervical dystonia, in essential tremor, but also in Parkinson's disease. And the problem of overstimulation and poor titration of the effective stimulation amplitude is somewhat inherent to this kind of clinical approach of using acute response testing. So, as a kind of a model, as an option, basically to get an account of the optimal stimulation space, we know that Chris Batson and Cameron McIntyre were working on these kind of axon models to model basically the extent of electrical stimulation and the effect on axons in the surround of the electrode. And this has led to the VTA models that we have available today. The workflow is that you identify basically on MRI the individual target anatomy of a patient, and then you can either use or not use DTI, for example, to specifically identify the orientation of fibers. Then you model the lead location, usually by image fusion of CT and MRI, and then you can construct from the stimulation parameters an electrical field distribution. And by placing an axon model at certain distances around the electrode in a grid, you can identify the distance at which you can still excite axons of a certain specific conduction velocity. And this is underlying the idea of the VTA model that we are seeing here as a result, where we can in 3D depict the location of the electrode in the individual patient-specific anatomy, and then in red we see this blob of fibers, axons that could potentially in the surround of the electrode be activated by our electrical field. Now these kind of VTA models give a certain visualization of the distribution of clinical effects and the effect volume within a given patient, but they can also be used to answer the one question that we are really interested in: where is the optimal location? Because if you just look at the distribution of electrical current in a given patient, this is still not answering you what is the optimal site that you should need to stimulate in a larger population of patients. So we would have a kind of a triangulation and GPS system without the map. And Google Map works because you have a good map of the surrounding, and you also, which would be our stimulation response map, and then you can put your individual triangulation, the location of your car, in correlation to the outside map to reach your optimal goal. And along with the development of the VTA models, there have been numerous studies that have tried to find sweet spots, optimal stimulation volumes or areas or regions, anatomical regions for different targets. These are some examples of the attempt to identify optimal locations with different methods for the subthalamic nucleus, where there is a kind of a general agreement that the dorsal lateral aspect of the subthalamic nucleus and the posterior aspect is preferential in terms of clinical outcomes. Now, there are a lot of caveats about the so-called sweet spots. They rely on the concept that there is a single sweet spot for treating a whole syndrome, which is not necessarily the case. If I use UPDRS points as a correlate, it doesn't tell me whether I preferentially improve tremor, rigidity, bradykinesia, gait, and there is good evidence, at least from pathophysiological studies, that the networks we have to treat for improving some of these symptoms are not identical, at least not for tremor, bradykinesia, and gait disorders, where obviously different networks are being involved. And this is one of the problems. The other one is a statistical one. If you are always preferentially targeting one site because you have an a priori bias towards a certain target in your center, then you are definitely not covering the entire area in a way that you are statistically representing the entire target volume, potential target volume, and then you will basically converge always to the mean of your own targeting bias. So that's another issue. You would need basically most likely multi-center data and big data of electrode positions from a large number of patients to cover an entire region, so that you have a good representation of different stimulation volumes with their negative and beneficial outcomes in order to find really representative maps, stimulation response maps. This was tried in this study for dystonia, where Martin Reich collected from a multi-center trial in Germany almost 100 patients who had GPI DBS, palatal DBS for dystonia. And here we reconstructed a probabilistic map, not really a sweet spot. So this is not a thresholding approach where we look at the number of voxels that have been hit multiple times in a common anatomical space. We did this calculation and it ended up with this green area here in the ventral portion of the GPI, ventral medial portion of the GPI. But this is just the tip of an iceberg. And the distribution that you're seeing here color-coded in red and in blue is giving you an account of the probability of a good outcome for each and every voxel. And as you can see here, there is a very wide area within the GPI with good outcome regions. And there is a tendency from medial to lateral for poorer outcome if you go towards, with your electrode, towards the GPE. So it would be a failure to assume that if you are targeting this one blob, which is a thresholding effect, a statistical thresholding effect, that you will always have excellent outcomes in your dystonia cases. And in fact, we have now an artificial intelligence algorithm who can predict, based on an individual electrode location, the optimal settings for a given patient. And this algorithm actually can predict good outcomes, optimal outcomes in a given patient based on the actual electrode location, which is inherently variable, because we heard from Cordula that this is a very complicated procedure with some, inherent error of reproducibility also, and this needs to be taken into account post-operatively then by the programming algorithm. So, as I mentioned, a lot of this workflow has now been implemented in commercial tools, and Boston Scientific, together with BrainLab, is offering an integrated solution not only for the surgical planning with BrainLab elements and the implantation procedure, but also for the post-operative reconstruction of the 3D images of the individual patient anatomy, as is depicted here. And then an integration of these images of this individual patient model into the programming platform, so that you have the imaging information immediately available as a neurologist when you are sitting in front of the patient, and you can observe the clinical responses and note the clinical response in correlation to a particular image of the field distribution that you are producing, a model of the field distribution that you're producing with electrode settings, polarity settings, for example, and amplitude settings. And then this tool also allows to collect data in a common reference space to do big data analysis. There is a tool which is called Quentry, which in principle allows the reconstruction of some of these maps specifically for your own center, or to pool data with different centers and to create your own specific clinical response maps, and to use these kind of clinical response maps also for your own quality control. And I would now like to explain a little bit more in detail how we have implemented this kind of workflow in Würzburg. Cordula has mentioned already a lot of this from the surgical part. We have preoperative non-stereotactic MRI and general anesthesia, which is the basis for stereotactic target and trajectory planning. And on the day of the surgery, this is fused with intraoperative CT. And then on postoperative day 1, we have a postoperative CT control to control the electrode position and possible bleedings. This is done with a high resolution 1 millimeter slice CT, so that we can reconstruct the electrode path. Of course, on day 1 after surgery, there is a problem very often of air inclusion of plumencephalus, and so that there may be some shifts of the electrode, but this is also mostly done to control for asymptomatic bleedings. And then after 4 to 12 weeks, we usually perform a full head 1 millimeter CT with the electrodes aligned to the gantry, which means in hyperextension of the neck, which is the best way to reconstruct the electrode position, and then to use the algorithms within the BrainLab software that allow to compensate, to identify the rotation of the electrode in relation to the ACPC line. And then we reconstruct the patient-specific VTA model for kind of a visual programming approach, and we use this patient-specific VTA model then on the computer to have a kind of a stimulation, virtual stimulation visit to predict basically the region where we believe we should start our search for the optimal stimulation response. So this is our workflow: the preoperative MRI image, the fusion of pre- and postoperative imaging, the identification of lead location, the patient-specific anatomical VTA model which is being identified, and then the Guide XT or StimView XT programming visit, which is done by the neurologists, who are then going to the patient with that kind of model and validating, who are validating the clinical response. So we are not doing a full screen of the entire electrode, not a full monopolar review, but we rather verify our hypothesis about a particular electrode and stimulation setting. And then we search around this electrode the space for an optimal response in terms of effect and side effect. I'm going to show this in a second. And this information is then fed back to the neurosurgeons. We have a common DBS, a joint DBS board every week where we discuss cases that had preoperative evaluation for the eligibility for surgery, but we also discuss the previous surgeries and we feed back the information about clinical outcome, and we review the cases together with the anatomy, which is our common understanding basically of a patient. It now allows us to discuss basically in relation to the individual patient anatomy the clinical response. So this is the kind of information that we can obtain. We can also use DTI information about tracts, the anatomical location, and this is the kind of image and screen that we get now on the programming console when we go to see a patient, to visit a patient, and to set the stimulation parameters. Well, where is the optimal anatomical site for stimulation? This is, of course, a matter of debate. If you look at different centers, this was a small review that Wolfgang Hamel did some years ago, asking DBS experts where they think on Schaltenbrand-Atlas is the sweet spot, functional sweet spot. It also tells you something about the targeting bias of different centers, because different centers have different preferable anatomical targets. But in the end, we have to review on a case-by-case and individual basis the clinical response. And this is what we do in clinical programming. It is now aided by having a kind of an initial setting, a starting point, where based on anatomical constraints, we believe we are stimulating the region which is most likely, in most cases, responsive to, for example, SDN stimulation, which will be the dorsal, posterior, and lateral aspect. And we can start with this setting, but then we can verify basically using a method that we call beam searching or non-zero programming, the region around this optimal setting. This is possible with the Boston Scientific programming platform because it allows, with these kind of cursor tools, to virtually move an electrical field up and down along the electrode and then around the electrode in rotational mode. So the idea would be basically that we have a certain starting point, let's say here between the lowest and second lowest contact, and then we can explore the space by keeping the stimulation volume identical and the stimulation amplitude. We would choose a relatively low amplitude, such as 1.5 or 2 milliamp, where we would see a good clinical response if the sweet spot is being stimulated. And then we use basically anatomical location of this electrical field as a variable. And we observe the clinical response, and we try to identify, for example, the region at which we have the best amplitude, the best suppression of rigidity in subthalamic nucleus stimulation, or we observe, for example, ongoing tremor when we are programming a patient with tremor. And this is done by continuously monitoring the symptoms and moving the electrical field up and down until we have identified the level along the electrode where we are seeing the largest symptom suppression. And once we have identified the level, we would then focus the electrical field 100% on a single contact, and then we can use these kind of rotational buttons here in order to rotate the electrical field then around the electrode. And this is the way that we verify clinically basically the optimal stimulation volume that we have basically hypothesized before on the programming console based on With this kind of workflow, we have substantially cut down the programming time in our center. The initial programming time is around, I would say, half an hour per site, per hemisphere with this kind of approach. And very often we see a good congruence, almost always we see a good congruence between the clinical response and the expected best stimulation volume from a visualization. There are, of course, a number of caveats in the reconstruction of the model, etc., and these need to be taken into account. And what I would like to show to you now at the end is a clinical case, how this kind of also interdisciplinary discussion based on the same model of individual electrode location can then lead to clinical decision making. This is a case where we had to do some troubleshooting. This lady, as you can see, has a fair response to subthalamic nucleus deep brain stimulation. This is after surgery, and she has residual bradykinesia in her off state. We tried to optimize the programming for the left hemibody, which is still very bradykinetic. On the right side, we have a quite good response. And the problem when we were visualizing the lead location was she had an almost complete withdrawal of dopaminergic medication by that time. With very small dosages of levodopa, she would get choreatic dyskinesia on the right hemibody, which was indicating a very good placement of the left electrode. But there were persistent off dystonia. You also see some cervical dystonia that she has in her neck, and bradykinesia on the left side. And as you can see here in the VTA model, the electrode is well placed in terms of AP and laterality within the center of the subthalamic nucleus, but it's too deep. And we are not reaching the dorsal aspects of the nucleus with our directional contacts, and we have difficulty to reach anyhow the optimal area in the dorsal aspect of the STN. With the upper contact, we get the best clinical response, but we cannot push the electrical field higher. And then, after discussing this case with our neurosurgical colleagues, we made a decision to revise this electrode, and this is one of the cases where we performed an electrode lifting after careful deliberation. And this is what you will see here. This is the electrode position after electrode lifting, so the electrode was simply withdrawn by 2 contact levels. And now you can see the modeling here. So we can adjust the electrical field in the VTA in a way that we are stimulating now through the directional contacts and reach the dorsal STN area and the white matter above the STN, which in our experience is very often very helpful in achieving the best anti-akinetic effect and anti-bradykinetic effect. And this is the outcome after electrode lifting, the immediate outcome after electrode lifting, much better amplitude of movement, much smoother, so that our prediction of stimulating too deep within the STN was actually confirmed now by the result of electrode lifting. In summary, we have now really an integrated solution for surgical planning and model-based programming prediction, which is commercially available and which we are actually using in our daily clinical practice. It allows to visualize the electrode location and also our programming choices, which is helping to optimize volume of tissue activated to guide the initial programming choice and to evaluate the appropriateness of clinical programming choices. It also allows us in a kind of an interdisciplinary conference to evaluate the need for possible lead revision in some cases. And it is the basis for documentation and information exchange between the neurosurgeon and neurologist during the follow-up of patient management. And of course, it is very helpful for education and quality control in our hands. Thanks a lot.
Jens, as usual, thank you for an excellent talk, and I'm really grateful that you showed that experience of approaching patients with suboptimal outcomes as a multidisciplinary team. I think this is a really important part of the multidisciplinary team, not just patient selection, but also bringing patients back to the surgical team by the neurologist when you haven't achieved what you wanted to achieve to discuss
Right.
that. So that's a really great example. Are there any questions from the floor before I start going through my list?
Yes, please.
Hi, I'm Russell from Newcastle. Thanks very much for your presentation. With all of the extra information that you've been able to gather for patient outcomes, etc., how is this? How have you related this to your discussions pre-surgery with the patients? Are you more able to give them a more precise percentage of improvement that they're likely to get, or you know, say in the dystonia patients, how many might not respond? I don't know if that's.
Yeah, I mean, you saw in Cordula's lecture, you saw that if you take basically a responder analysis, we have, I mean, in Parkinson's disease, you have a benchmark of what you can achieve, and the benchmark is the levodopa response. So what we use to evaluate, to do a quality control of our own work, is basically we look at the response, the stimulation response in relation to the levodopa response, and these were the numbers that Cordula was showing. And if we have a patient that has at least 75% of the levodopa response mimicked by stimulation, and that's also usually represented by a massive decrease in dopaminergic medication in these patients, then we call this patient a responder. And the responder rate, if you analyze this, is quite high in our center. So it was, before directional electrodes, it was already above 80%, and it stabilized at something like 85, almost 90%. So it's very difficult to show an improvement by all this methodology. But what I think what we are achieving is we are achieving this with larger consistency, with higher reproducibility, with shorter time in individual patients, and we use less energy, which is also, I think, a marker of quality, because you're not diffusing the current so much, and this also ultimately will feed back on adverse effects, for example, on these long-term adverse effects like dysarthria, gait freezing, etc. So will this show up in clinical trials? I don't know. But it's making us, I think, more confident with our own work.
Jens, I have a question for you then. We have the impression that it's easier to evoke dyskinesias when using directional leads than when using the ring leads. And sometimes this actually stops you from increasing the power as much as perhaps you would like to achieve the best outcomes. So I have two questions. Number one, is this your experience? Because I've heard from a number of centers that it is. Of course, it isn't a head-to-head comparison, but could this explain some of the reduction in energy that you're using?
Yeah.
And that's not necessarily a good thing, if you see what I mean.
Seeing dyskinesia with ST and DBS, I always explain to the patient that this is a good thing, because we want to mimic the levodopa effect, and usually the best levodopa effect in patients with dyskinesia is in a dyskinetic state. So we are imitating this. In the long run, it's hardly ever a problem, because there is habituation of dyskinesia with continuous stimulation if you don't do pulsatile stimulation with dopaminergic drugs. So I don't see this as a long-term problem. I rather see this as a biomarker for the sweet spot. And if you can stimulate the sweet spot with a much lower current, this means that you are better on target.
I must say it's been our experience that sometimes, not in all patients of course, but sometimes it's difficult to get patients on but not dyskinetic.
Okay.
So sometimes they're on and dyskinetic, but then you don't have that therapeutic window that you were talking about earlier, where you can't get them on without them being dyskinetic.
You have to be very careful, and that is one of these issues where you see different time courses of symptoms to evolve. Dyskinesia may come quicker than the antibradykinetic effect, actually.
Jens, I've got a question for you, because it's something which is not so clear for me. I look at the way the neurologists are dealing with the directional leads in our center. They have the patient with the leads implanted, so they have the possibility to use a ring mode, and so I look at this retrospectively. And after 3 months of stimulation, they were almost, I would say, 80% in ring mode. Then I saw that they switched to the directional modes, and for me it's not clear what is the reason why they do this. And usually there is mainly 2 reasons. One is the obvious, is the threshold of side effect. They see that some side effects are limiting the stimulation, so it is logical. And sometimes it's because they try to do better. They have good outcome with one ring mode. They try to do the same with directional mode. Seems to be the case in some cases. So what's your feeling on this, and how do you deal with this?
Well, I mean, mankind is used to habits, and we are following habits very much. So, I mean, if we are used to do ring mode programming and we want to reduce the complexity, then we do ring mode programming. So you will not see an advantage, of course, of directional stimulation in a given patient if you don't start using the system with all the complexity and all the options that it is offering. And of course, I mean, the way that you program, if you use, for example, this kind of a beam searching approach, then you are completely eliminating the idea that an electrode has physical contacts, because what you are doing is you are stimulating volume, irrespective of the physical contacts. And the MICC capability of the Boston Scientific system allows you to stimulate volumes that are in between contacts. Basically what we are doing is we are leaving, we could have a stick in there with an active area and not visualizing the contacts at all. We are just visualizing the volume that we are stimulating. And I think this is appropriate for such a system in order to use the capability of the system. Otherwise, you are following a concept of an old hardware. And of course, you can program this system to be like a Medtronic quadrupolar electrode, ring electrode, but I think this is not the purpose. It was not designed for this.
I mean, I think the fact that you have the multiple independent current control is really important, because actually it doesn't matter what orientation your lead is, because you should be able theoretically to make any shape of electrical stimulation, whatever the orientation is. It's nice to know what the orientation is, because then you can foretell what the shape should be. But we're running out of time, but I'd like to thank both speakers for their excellent talks and lovely discussion. Thank you very much, everybody. Have a good rest of the day.